Hi, everybody, again, for some of you, and for some of you, the first time, hi. I'm Wen. I'm a faculty of NYU Global Public Health Biostatistic. Welcome to the Public Data for Public Health application to MNC event, which is hosted by NYU GPH Biostatistic jointly with Open Data Week 2025. And we have a very great collection of bunch of students from our department to talk about their cool research involving data from MIC or in general. And without, again, really sorry for the confusion of multiple room. And without further ado, I would like to maybe Zach give a quick introduction. Then I will talk about then we'll talk about then the student can start their presentation. But before Zach talk about, I just want to quickly introduce our students. We have four speakers today. The first one is Nate from our own department. He's going to talk about a quasi-experimental study of New York City's sodium warning regulation and hypertension prevalence. And the second speaker is also from our own department, Zhiyuan from Biostats, and he's going to talk about relationship between the cycling and the prevalence of hypertension among adults in MIC. And the third one is Annie Chu, is also our student. She's going to talk about analysis of potential difference from inpatient and outpatient satisfaction among sexual orientation and gender minority oncology patient. And actually, I help Annie with her slides. Her talk is very cool, and I think it could be quite useful for, or quite interesting for many of us. And the last one, Andrew, is also from our department, and she's going to talk about timing of non-cardiac surgery and major adverse event after cardiovascular interventions. Maybe the first person, since Nate is not here yet, and the Valdi will play his recorded talk, maybe.
Hi, I'm Nathaniel Maxey. I'm a second-year master's student at New York University studying biostatistics. And today we're going to talk about hypertension and NYC sodium warning regulation. So just to read off the grandiose title for you guys, it's the quasi-experimental study of New York City sodium warning regulation and hypertension prevalence over from 2005 to 2020. So we're looking at age-adjusted hypertension rates over time. I'll talk more in detail about why we're looking at this and more of the deeper public health impact, but we'll go into it. So on my next slide, we're going to talk about the background and significance. So why do we care about hypertension? Hypertension impacts me. So my dad has had hypertension for years. He had really high blood pressure. And he had poor hypertension management. He ended up having a few strokes, which impacted my family, my life course, and everything like that. So something that I always thought about was why didn't he take his medication or anything like that? But it's something that's always been in the back of my mind of like some of the factors playing into the causation of like hypertension. So one thing that's similar is that hypertension impacts a lot of different groups of people, different marginalized groups, like Black and brown communities, especially in New York. So I saw like the intersection. This is the reason why I picked this topic. So just to talk, hypertension is the primary contributor to heart disease and stroke, which are leading causes of deaths of New Yorkers. Um, Excess sodium can exacerbate these risks for increasing blood pressure. This excess sodium is not too good for your body and everything. So to combat this, the NYC Department of Mental Health and Hygiene on December 1st, 2015, implemented this regulation. So it requires chain restaurants with 15 more locations to display a sodium warning icon with a triangle to salt shaker. So if you go to like Chipotle, you'll be able to see it. So if you look a little closer, or in McDonald's, you'll see it on certain items that it's basically indicating that this food has more than half the daily value of what you need. Now, your daily value is something that is that nutritionists have figured out how much sodium you need in the 2,000 calorie diet. And sometimes certain fast foods, they overexceed this. And what I was talking about earlier, excess sodium consumption can exacerbate congestive blood pressure. This is why they're doing this. They're trying to explain to people that, hey, this food that you're eating, that bowl at Chipotle, might be half the sodium that you might need in the day. Now, you don't know how much people are actually eating, but imagine you ate 3 meals like that, and there's excess sodium. So that's not always super, super good. Again, It's just the menu items are just telling people it's exceeding 2,300 milligrams of sodium, which is a lot. So basically, the point of this policy was to improve health outcomes and increase awareness of high sodium in fast food restaurants, so people understand what they're buying, what's in their food, and how is it impacting their health. So my research questions was, I was wondering, did the average annual percent change in age-adjusted hypertension prevalence differ before and after implementation of the regulation? And then my second one, are the changes in age-adjusted hypertension prevalence are associated with trends consistent across racial and ethnic groups? So I wanted to see, this is how I broke it up. There was a pre-implementation period, which was from 2005 to 2015. The onset was from right when it happened, 2015, and then and then regulation period, which was like 2016 to 2020. I wanted to see the average annual percent change between these three groups, and I also wanted to see strata by race and sex at birth if these trends differed, which is important because it hypertension impacts different socio-demographic groups in various ways. So my hypothesis is that there's a significant association between the implementation of NYC study morning regulation and a reduction in age-adjusted hypertension prevalence among white individuals. And then my second one that I posit is that the sodium warning regulation does not show significant effects on age-adjusted hypertension prevalence among Black and Hispanic. And just to explain why I say that white individuals will benefit from this is because they experience greater benefits from the sodium warning regulation due to differing access to resources and health promotion. Um, and then my second hypothesis is that Black and Brown communities who are more impacted by the broader social determinants of health may not experience significant reductions in hypertension prevalence because of sodium warning regulation. I think it's just due to the burden in the community that I don't think this one policy can eradicate hypertension. But these are my hypotheses. Right. So my methods. So let's just talk about, I always like to talk about the data set. So this is NYC Open Data Week. We use the NYC Community Health Survey. It's an annual survey on health topics like the stuff about cardiovascular stuff, smoking, other health related issues. It was conducted by the NYT Department of Mental Health Hygiene, covering around 7 to 10,000 adults 18 plus. So let's talk about sampling. How do they get their people? How do they sample? Random phone lines and only one adult per household. Um, from 2005 to 2008, it was landline only, and then 2009 they switched. They included cell phones. So, which is really cool, and I love this, is that there's a lot of languages that it's translated into for this survey. It's English, Spanish, Russian, Chinese, Bengali, and Haitian Creole. So there's a lot of different languages, but this is something I'll talk about more later on. Waiting wise, I waited using the census, the American Community Health Survey, which is at ACS, and the house vacancy data too. That's how I weighted my data. For the age adjuster, the hypertension prevalence was age adjusted to the 2000 US population. The axis is de-identified and publicly available, so I'm scared there's no IRB because this is data online, which is real cool that we have access to as Americans. And the population was 18, well, it was adults 18 plus from all 5 boroughs, and they're randomly chosen from each household from that sampling method I was talking about, with the changes depending on the year. And their big question you're asking me is, how did you decide who had hypertension? So there's a question right here. It was, have you ever been told by a doctor, nurse, or other health professionals that you have hypertension or so-called blood pressure? So self-reported, which I'll talk about more limitations, but this is just something, a criteria. So I can have I can have a population I can subset from. And this is what the question that we used. All right. I'm gonna walk through this scary equation, but we'll be able to understand this. So these are just my predictors. So my outcome. So this is what we're looking at. I'm worried about age-adjusted hypertension prevalence in years. Okay. But you're wondering why is there a natural log right here? So one thing that's nice about natural logs is that when you take the natural log of our outcome, it helps with normalization. So And then especially with linearity and stuff like that, you don't want your data to be skewed or anything like that. Um, so for beta naught, this would be like the baseline at expected well, it'll be the baseline age-adjusted hypertension prevalence in years in T. T denotes the number of years from 2005. X sub T is a sodium warning regulation indicator. For XT 0, it's before, and then for XT equals 1, it's after regulation. And then the difference between T1 and T9 is the time elapsed between, which will we also see the percentage point differences too. Again, that beta naught parameters intercept, which represents the baseline age-adjusted hypertension prevalence. Beta 1 is the average annual percent change in age-adjusted hypertension prevalence before their sodium warning regulation. So that's that coefficient right here. Beta 2 estimates the percent change in age-adjusted hypertension prevalence immediately following. So remember I was talking about the three groups of subset before, when the period just happened, and not. So before, again, just to reiterate, is 2005 to 20. I think it would be 2014 technically. 2015 is the onset year. 2015 to 2020 is the regulation year. So again, just to say, just jog their memory about how I divided, how I was looking at this over time. Beta 2 is the estimates of the percent change in age-adjusted hypertension prevalence immediately during. So this was in 2015, and beta 3 would be 2016 to 2020 estimates the percentage point differences in the average annual percent change before it was implemented, and the average annual percent change during the regulation. All right, so these are the most important ones. If you ever want to reach out to me and read the paper, I do have more detailed results if you're more interested. But for the stuff that was significant, and then there's a 95% confidence interval, so our alpha was 0.05, but we found a statistically significant average annual percent increase in age-adjusted hypertension among the Hispanic population. It was 1.3%. And then also reported that confidence interval. So there's a spike, and for some reason, there was a spike in hypertension prevalence. There's not really a real way to tell from literature like why that happened. There's a lot of factors that point into, and you can try to argue and assume. But for me, as a statistician, I will just say there's an increase, and we saw that over time. But I couldn't give you like a definitive explanation of why that happened at a population level due to like the ecological fallacy. So for the regulation onset, this is at 2015. Remember, December 1st, 2015 is when they implemented this. Regulation onset was significantly associated with a 4.1 increase in age-adjusted hypertension prevalence among people who identify as women from 2015 to 2016, and that's really significant. There's something going on around that time that there was an increase in the hypertension prevalence. I'm not sure. I'm not why I can't really say I'm not a public health professional. I'm a statistician, so I would have to do more and get more domain knowledge to figure out what was going on. And then during the regulation year, we observed a statistically significant average annual percent decrease in age-adjusted hypertension among Black and female. So for Black people, it's 1.9, and for people identified as women, it was negative 3.6. So coming back to my results, remember I was saying that I thought it wasn't gonna work for Black and brown people. So I ended up seeing a percent decrease. Now, there's a whole thing, or you're thinking in the back of your mind, that this menu item actually caused that. No, we're just the cutoff of something observed over time looking at population data. So I'm not making a causal claim saying this policy caused that, but more in a sense, something just associated change that we see over time. It's just a red flag. Well, not a red flag. It's just a flag up to scientists, public health researchers, and people like us. All right. Public health implications. These findings emphasize the need to monitor and evaluate sodium reduction policies over periods of time. So to track it longer, probably should do some real RCTs to understand how people are deciding for menu labeling and how much sodium they're consuming. I also think there needs to be targeted populations, even if there was a decrease. So my whole thing was that I want to see a decrease for everybody, especially in marginalized communities too. but I want to see the health and wellness for New Yorkers get better. So the whole goal is to just improve human health. So there needs to be targeted interventions for Black and Brown communities, even more where they do need it, even in white communities, reassess and see if these policies are actually working. So one thing you're wondering, what's the whole point of this? I think that it's nice to track data over time. It gives flags to scientists, public health people to test more and figure out what's the real problem. But it's a first step to exploration and to understanding a deeper, nuanced problem that we don't know. This could be the first step, and someone could continue it, or it could be me. But uh, this is one thing I always talk about: is study limitations. So segmented regression analysis assumes linearity, constant trends, and the deviations might impact the results. So there's some self-reported bias. Self-reported data is subject to recall bias and social desirability bias, which may lead to inaccuracies in health diagnosis. That's what I was talking about earlier with the self-reported hypertension question. That's something you always got to think about. Some epi skills that we learned. And then for the participants' interpretation of medical terms may vary across different languages. So before, that's why said how the languages there were. It was a lot, but different health concepts don't always translate differently. There's not always a cognate in language when trying to understand something. So if I ask you something in Spanish in a different way, the translation might be different. So like even I know that they try their best to make sure it's geared towards the survey, but it's never perfect. So there could be some form of misunderstanding that you didn't know when someone's taking a survey in Bengali or Haitian Creole or whatever. It just depends on the arbitrary language. And then again, I was talking about the single measure question. I think there should be a validated one from a doctor or like a blood mark or something. I think those are more things that could improve on next time. And then I'll talk about the misinterpretations and everything. So, well, these are some of my references and stuff. If you want to read the paper, just reach out to me. My email is njm9948@nyu.edu. Um, so it was my original thesis before I had to change, but something I'm really passionate about. My family's impacted by hypertension, and that we all should care about it. And it's something that could happen to anybody. So hope you guys have a great day.
Okay. Well, thanks, Nate's presentation. Well, he's not here, but the presentation is very interesting. I think now we're going to pass to our next speaker. Again, if you have any questions about Nate's presentation, feel free to reach out to him directly, and his contact information is on this event. And our next speaker is Zhiyuan from our own department. He's going to talk about the relationship between cycling and hypertension.
Okay, hi everyone. My name is Zhiyuan, and I'm a second year MS student in biostats at NYU GPH. I'm very happy to share my work in the Open Data Week. So let's get started. Well, my research topic is the relationship between cycling and the prevalence of hypertension among adults in New York City. Well, hypertension or high blood pressure is a main public health concern, affecting nearly half of adults in the United States. As a chronic disease, hypertension is often referred to as the silent killer because it typically shows no obvious symptoms in the early stages, yet it can cause irreversible damage to the cardiovascular system and other organs. Well, some research shows that men are more likely to report hypertension than women, and the prevalence of hypertension among non-Hispanic Black adults is the highest. Well, key risk factors contributing to hypertension include, like unhealthy diets, excessive alcohol consumption, obesity, and physical inactivity, etc. We can notice that some of them are closely tied to, like lifestyle and behavioral factors. So, what about the treatment? First, pharmacological approaches. There are various medications that can help us control the blood pressure. Well, for our research, we won't spend much time on it, but it is important to know that most medications which can help control blood pressure may cause side effects, which could potentially harm the body. Well, so the second, lifestyle-based approaches, as we mentioned before, hypertension is closely tied to, lifestyle and behavioral factors. So, for example, healthy diets, limiting alcohol, regular exercises, quitting smoking, etc., can help us control blood pressure. But some research shows that regular aerobic physical activity, such as walking or running, can significantly lower blood pressure. Well, when it comes to physical activities, most studies focus on the effect of general physical activity on hypertension without delving into specific activities. And few studies have examined the relationship between cycling and hypertension. Even fewer studies investigate this relationship within New York City's population. So let's take a look at cycling first. Cycling is an accessible and low-impact form of physical activity, well suitable for people of all ages. And bicycle use in New York City has increased significantly over the past decade, supported by the expansion of bikes lanes and public bike sharing systems, for example, City Bike. As a sustainable and affordable transportation option, cycling can also help reduce traffic congestion and the environmental pollution. But given that cycling is such a beneficial form of physical activity, our study aims to explore its association with hypertension and try to provide some lifestyle insights for the health of New Yorkers. So, the research question is that what is the relationship between cycling and the prevalence of hypertension among adults in New York City? We have a hypothesis, which is that those with higher cycling frequency will be less likely to report hypertension, controlling for age. In addition, it is expected that this relationship will be modified by gender, with men having high cycling frequency less likely to report hypertension compared to women having high cycling frequency. The reason we made this hypothesis is that, as we mentioned before, men are more likely to report hypertension than women. The data for this study comes from the 2020 New York City Community Health Survey, an annual cross-sectional telephone survey conducted by the NYC Department of Health and Mental Hygiene. The sample we used includes 8,435 residents aged 18 and older. This survey is population-based, explores stratified random sampling design. Eligible participants are adults residing in New York City with either a landline or mobile phone. Data is collected using a computer-assisted telephone interviewing system. So the outcome is hypertension, of course, defined like this. The systolic blood pressure is greater than or equal to 130 millimeters of mercury, and or the diastolic blood pressure is greater than or equal to 80 millimeters of mercury. Participants self-reported their hypertension status by answering whether had ever been diagnosed with hypertension, with responses categorized as yes or no. Well, the exposure is cycling frequency, measured as how often participants rode a bicycle in New York City in the past year. Responses were categorized into 4 levels: never, several times a month, at least once a month, and a few times a year. The potential confounder is age, and the potential modifier is gender. Well, here is our analysis plan. For the univariable analysis, we summarize the data using descriptive statistics, reporting frequencies, and proportions for key variables. For variable analysis, chi-square test was exploited to evaluate relationships between pairs of variables, since all of them are categorical. Well, for multivariable analysis, logistic regression models were used to explore the association between cycling and hypertension, while controlling for the confounder. An interaction term between cycling frequency and gender was added to assess whether this association is modified by gender. Well, first, let's take a look at some preliminary results. Well, the figure on the left shows the unweighted frequency and percentage of hypertension, which is just based on our sample. In our data set, nearly 30% people have ever reported hypertension. Well, this is not as high as what we mentioned at the beginning, but this is still a significant proportion. Well, the figure on the right shows the weighted prevalence of hypertension. In other words, this figure reflects the distribution of hypertension among the overall population of New York City. We can notice that the proportion of hypertension is relatively lower than the left, but 25% is still high. But next, let's see the results of logistic regression. Well, first, the weighted model without the interaction term. Here are the interpretations of the coefficients of this model. After controlling for age, compared to adults who never read a book in the past 12 months, those who read several times a week have 33% lower odds of having hypertension, while 17% lower for writing at least once a month, and 42% lower for writing a few times a year. Well, we can notice that people riding bicycles are indeed less likely to report hypertension. But here is an interesting thing: a higher frequency of cycling was not consistently associated with a lower likelihood of reporting hypertension. And those who ride a few times a year have the lowest odds of having hypertension. Well, this is just what the model tells us. Well, for the model with interaction term, unfortunately, the interaction term is not significant, which means that gender will not modify this association. Well, actually, in the bivariable analysis, we found that the relationship between hypertension and gender was not even significant based on our data set. This means that in New York City, men and women have similar chances of having hypertension, which is different from what we see at the national level. Since it is not significant, we won't spend much time on it. So after the analysis, the model tells us that in New York City, people who ride bicycles are less likely to report hypertension compared to those who never ride. However, the relationship may not be dose dependent. Well, cycling more frequently does not necessarily lead to lower hypertension risk. Maybe this suggests a potential threshold effect, where some cycling is beneficial, but more is not always better. Maybe regular but moderate cycling might be better. So this may inspire us to try to find the best frequency of cycling in the future, or maybe we can examine more covariates using different models to further study this topic. Well, thank you for listening, and feel free to ask any questions.
There's a question here. Can you repeat which data set you used to get hypertension data? Juan, do you mind
Yeah,
to provide the?
it's New York City Community Health Survey 2020. It's the same survey as NACE, but I'm not pretty sure if it's the same year. But just here the data set.
There's another question. Why did you take only one confounder age? I think sort of like limitation of the analysis. Maybe you can give.
Yeah. This might be the limitation of my study, but no, it's just what we designed at the beginning. So maybe more covariates or more confounders could make the results more meaningful. So we will try it in the future, maybe.
Okay. Thank you, Juan. It's great talk.
Okay. Thank you.
All right. Our next speaker is again our student Annie Chu from our second year master student in biostats. She's going to talk about potential difference from inpatient and outpatient satisfaction.
Good afternoon. My name is Annie Q, also known as just Q, and I am a second year MPH student with the biostatistics concentration. I am so glad to have the opportunity to talk to you about some of the work that I've been doing at NYU GPH in the last couple of months. Today, I would like to present part of my thesis work, and I welcome your feedback towards how I can improve upon my efforts so far and what more I can do in the future. My topic is on analyzing potential differences between inpatient and outpatient satisfaction among sexual and gender minority oncology patients in New York City. In this presentation, I will be using the term SGM to reference the sexual and gender minority oncology patients that I looked at. So, upon receiving a positive cancer diagnosis followed by intensive treatment and ending in potential unfavorable prognosis, oncology patients in general can experience a certain level of stress. This could be even more amplified by a variety of factors, including but not limited to lack of knowledge exchange between providers and patients. For example, was there ever a time that you or your family members have been just handed discharge papers without more instructions than just read this, follow the plan, come back in 2 weeks and we'll follow up then? Was there a discussion surrounding feasibility and adherence to the plan? Secondly, absence of psychosocial care. What if you didn't know how to effectively cope with a severe illness or extensive trauma and heal from it on your own? This could potentially perpetuate a decline in your mental health over the years. Thirdly, long wait room time. For someone who had just been diagnosed with a terminal illness, every minute can count. Not knowing when they could be seen or taken care of could potentially lead to a higher risk of adverse events, not to mention even more emotional distress. So, of these oncology patients, I focus on the SGM group, which consists of individuals who identify themselves outside of traditional gender and sexual orientation norms. So, on the slide, you'll see a gender unicorn, and you'll notice that there are different combinations, many combinations, for what someone can fluidly identify as, how they express themselves, who they are interested in from a physical aspect, and who they may be attracted to from an emotional perspective. So this spans beyond the sex assigned at birth, which here are defined in categories of female, male, or intersex. So these SGM patients can actually face quite unique healthcare challenges as a product of several barriers, including implicit cis or heteronormative assumptions that exist within the care team, biases which can build up from a long time of societal expectations, lack of training within healthcare professionals' medical education, as the SGM patients are medical minorities. They aren't usually at the forefront of study. Then also having a generalized discomfort towards disclosing sexual orientation and gender identity, or also known as SOGI status, to care providers in the first place, which can come from prior trauma, from unfavorable and discouraging interactions when they disclosed their SOGI status before. So between all these stressors, challenges, and everything in between that an SGM oncology patient will face, how do we capture these and other patients' stories as they go about their appointments or are admitted for further procedures? An important conduit for enriching healthcare practice and delivery is utilizing tools such as questionnaires to systematically capture and evaluate what patients can go through during their inpatient and/or outpatient visit. In particular, I would look at the Hospital Consumer Assessment of Healthcare Providers and Systems, abbreviated as HCAHPS, which provides insight for inpatient admissions, and Press Ganey does the same for outpatient encounters. In terms of psychometric properties, these standardized questionnaires have good reliability. For the HCAHPS, the reliability target is 0.8, which is pretty high in relation from 0 to 1. And for Press Ganey survey, the reliability ranges from 0.79 to 0.96. To be eligible for this particular analysis, adult oncology patients should have the following criteria. They should have received care between 2021 and 2023 in a single center, research-oriented urban oncology treatment center of the United States Northeast, in particular in New York City. They should have responded to an HCAHPS or Press Ganey survey for their care. Those who have both an inpatient and outpatient encounter during this time would have returned both surveys would be excluded to avoid overlap. And also, lastly, have a recorded sexual orientation and/or gender identity status that is of SGM classification. The aim of my project is to investigate if there are differences between inpatient and outpatient satisfaction among SGM oncology patients. And to accomplish this, I will look at individual scores for select domains, particularly participating in decisions about personal care and addressing cultural and spiritual needs, in addition to overall aggregate score from the questionnaire responses. Then I will calculate a POMP score, which stands for percent of maximum possible score, before moving on to statistical analysis. We'll be getting into why prompt scores matter in a few more slides, and how it can accurately tell the story of what's going on in relation to survey scale responses. My analysis plan details how I will achieve these endpoints, as I mentioned previously. Firstly, the scripted summaries will be examined in the two independent groups of inpatient and outpatient SGM oncology patients. This will give me a bird's eye view of how my sample looks. Then I will explore the distribution of scores for domain-specific questions, sum scores, and prompt scores to determine if assumptions are met for either parametric tests that will work for the data that behaves normally and symmetrically, or if it should be non-parametric tests for other shapes of data. This would tell me how to proceed with the right type of analysis. Lastly, I will compare the scores to determine if there's a statistical significant difference and if that would tell us something more about the inpatient and outpatient SGM group. Following the analysis plan, I looked at the descriptive summary. There were 841 patients in total within the sample, 132 of them which have returned an HCAHPS inpatient survey for inpatient stay, and 709 which had returned a Pasquini survey after an outpatient encounter. Again, there were no overlaps between who had both stays, as these patients were excluded. Of these demographics, I would like to draw attention to this particular section, focusing on sex at birth, gender identity, sexual orientation, as my sample are SGM oncology patients. So think back to that gender unicorn slide from the beginning of this presentation and recall that how someone can identify their gender and sexual orientation outside of their sex at birth. So in further exploring the inpatient breakdown, as you see on the left side, we see that there are 132 individuals, 76 were female at birth. Among those female at birth, nearly 9% identified as either man or non-binary. Still within the same patient group, of the 56 patients who were male at birth, 88% identified as gay, and just about 13% identified as bisexual or something else. Similarly, we can see for the outpatient group, of the 297 patients who were female at birth, 5% identified as man, non-binary, and or transgender woman. We see that the inpatient group for these 412 patients who were male at birth, 88% identified as gay, and 11% identified as bisexual or something else. So following the next step of the analysis plan, I looked at the questionnaire responses, and I was faced with the age-old Likert debate. The HCAHPS and Pasquini surveys are measured on a 5-point scale, and the anchor points detail a standardized spectrum of responses between two extremes. The long story short, should we consider the numerical 1, 2, 3, 4, 5 scores as ordinal data or interval data? Because they range from very poor, fair, good, and very good. Now, my rationale is, although there are degrees of what's considered better and what's considered worse, the distance between each response are neither constant nor well-defined per respondent, in a sense that there's a lot of room to interpret the subjective response between people. So a good rating of service for me could translate to a poor or fair rating of service to you, based on your or my history of prior contextual experiences. Some other considerations for how these contextual experiences can influence a person's perception are biological factors, such as current state of pathology, inflammation, higher specific genetics could predispose you to some conditions over others. At the same time, we don't want to ignore the psychological factors, such as mood, emotion, if someone were prone to catastrophizing, or if someone had different proficiencies to cope with and manage stress throughout the time. Also, the behavioral factors are equally important to think about. If someone's sleep, diet, exercise, or even potential substance abuse or use can contribute to their positive or negative perception of experience. On top of that, tying it all together, what about the sociological factors? For example, if someone has the necessary social support, income, or education to understand or handle these stressors, especially since these SGM individuals experience increased rates of health disparities, like higher rates of mental health conditions, substance use disorders, and they can really benefit from trauma-informed care principles. So knowing all these components that goes into your perception, to address this heterogeneity, a prompt score can be used so that we can standardize the scoring from a scale of 0 to 100, meaning the score assigned to each individual is a percentage, reflecting the individual's position on the scale as a percent of maximum possible score that can be achieved. The formula is presented as the numerator having the observed, which is the observed score for a single case, the minimum, which is the minimum possible score on a scale, and the maximum, which refers to the maximum possible score on the scale. So due to the scaling method, we can achieve test statistics that will remain constant across transformations. And to manage this on a large-scale data set, the package Trust was used in R for statistical programming, and the function called prompt was used to recode the numerical vectors into a prompt score. So following all of this and the analysis plan, next steps would be visualizing the data. Preliminarily, we see that it does not behave like a normal bell curve would. Normal bell curve is shown on the bottom left side of the screen, where you have symmetry between both sides. And my data is reflected on the right. So we see initially that it doesn't behave like what a normal bell curve would do, not symmetrical. So we can't use an analysis that expects symmetrical input. The data are less skewed, favoring more responses of good, very good, which could be due to the prestige of care within the specialized cancer center, delivered by teams of world-renowned doctors, specialists, scientists, and also it could be due to the ease of access of cutting-edge treatments as soon as they are available in clinical trial enrollment. So because the data doesn't behave as normally as we would want to see, we would have to use non-parametric tests since the assumption of normality is not met. We can't do something like an independent t-test, let's say. So I guess in the interest of time, I think I have a few more minutes, but some lessons that I learned when working with real world data is that the data can be real world messy. So while it's initially messy to look at, once properly cleaned and the information is validated, this information can help with generating reliable insights towards making informed decisions. So when you prepare your data for analysis, sanity checks are quite valuable to include. So for example, would it make sense if a patient's date of death is prior to them having completed the survey? So I would have to look into those cases a bit more. And then understanding the data's context, specifically the data's origin, the structure, limitations, is crucial for accurate interpretation. So since my data spans between 2021 and 2023, which covers the height of the COVID-19 pandemic, and that was also when the FOGI statuses were starting to become a more standard practice to collect among patient encounters. So pandemic measures could have contributed to the patient's responses to what manner the care was delivered to them and how they received it. And if I were to collect data from an earlier time point, I would have had a lot of incomplete information about a person's FOGI status, leading to the SGM oncology patients who are already a medically underserved population to be even more invisible in the grand scheme of evaluations. Next, be fully prepared for your data to break all standard assumptions and stray from the rules of what you can see from something that is handed to you out of a classroom. So one of the ways that we can visualize that is when you're in doubt, plot it out. If your data is so non-normal that it kind of identifies as a Jackson Pollock painting, own up to it, right? Run the appropriate non-parametric test. Otherwise, the results may not be meaningful or reliable enough to inform downstream decisions that can impact a lot of people. You could be inaccurately representing a situation at hand, and your findings could be used for inaccurate interventions that could do more harm than good. And lastly, good contemporary data analytic practice may include statistical transformation of a variable in order to improve its distributional properties, and also about validity of our statistical inferences. For example, while the original scale has meaningful units, the interpretation of the results could remain problematic. So it's really important to try to understand what a meaningful effect might be in particular research area. So, for example, a 10-unit prompt score change in a simulated lab experience could be a very large effect. But in the real world major life experience, a 10-unit prompt score change could be considered as a small effect. It's all based on the context of what's going on. And I think I have taken up a bit of time, so I will pause my presentation here. Thanks so much for your time and attention. For part of my thesis work, I would like to give big kudos and appreciation for those who have stuck along this journey with me so far and providing me with such valuable input to keep moving upwards and onwards, especially Dr. Drill, Professor Wenzhou, Dr. Cordova, and many others. Feel free to connect with me at aq2071@nyu.edu. Looking forward to future collaborations, maybe more in-depth work in this field. Hope everyone has a great day.
Thank you, Annie. we can take maybe one quick question given the time, the interest of time. But here's one comment from the audience say, given the anchors, I'd go with ordinal data. Do you have any comment about this question or suggestion? Any?
Sure, yeah. That's definitely one of the debates for what is ordinal, what is interval. I think in one of my previous slides, I had experienced something that is, you know, more good versus something less good. But then my experience is not as the same as yours, right? The anchor points do matter where it has a positive negative balance. But in the looking at overall comparisons between people, then I think I would be more comfortable with the POM score transformation.
All right. Thank you. Thank you, Annie. That's a great presentation. And let's move to our last speaker for today. And it will be our student from Biostats, Andrew. Andrew, we're going to talk about timing of cardiovascular intervention. And Andrew, yeah, thank you. And now the floor is yours. Thank you.
So, hi everyone, I am Angel Singh and I'm a first year MS Biostatistics student. And today I will be presenting my research on the timing of non cardiac surgery and perioperative major adverse events after cardiovascular injury. So, this study aims to determine the safest time frame for performing non cardiac surgeries after a patient has undergone a cardiac intervention. So, the objective of the study is to evaluate the optimal timing for non cardiac surgery after cardiovascular intervention. The current guidelines suggest that we wait at least 6 to 12 months after the cardiovascular intervention has taken place to perform a non cardiac surgery. But there is very limited data on whether that is truly the safest period. And our research specifically investigates when the cardiovascular risk stabilizes and when it is the safest to proceed with the non cardiac surgeries in patients who have undergone procedures such as PCI or TAVR or MVR, replace, repair, and other cardiovascular interventions. I would like to give you some background on why we are choosing to investigate this objective and what the aim actually means. So, the current guidelines recommend delaying an elective non cardiac surgery after, let's say, a procedure such as PCI with drug eluting stent, which is also called as DES PCI, for at least 6 to 12 months to reduce the risk of complications. However, the real world data shows that about 3.5% of the patients who undergo a procedure such as PCI require non cardiac surgery within that 6-month period. Therefore, it's not ideal to wait until after 6 months or after 12 months, which also means that patients face a significant risk, such as 8.1% of the patients experience perioperative death or myocardial infarction or stroke if that time frame is not followed or if the surgery occurs in the less than 6-month period. A major factor influencing outcomes is the role of blood thinners, such as aspirin or other antiplatelet agents, which need to be held when performing a surgery. So, essentially, patients who have had a cardiovascular intervention need to be on lifelong blood thinners. But when they are put into a non cardiac surgery, those blood thinners need to be held back, which can complicate both a risk of bleeding and thrombosis prevention. Therefore, the study aims to clarify the safest time to perform the surgery while balancing these risks, and when it is the safest to hold those blood thinners and then perform a non cardiac surgery. Now I'll discuss the methods of the analysis and what the database looked like. So we initially used the Vizient clinical database, which includes data on non-cardiac surgeries performed from the first quarter of 2018 to the first quarter of 2024. We also included a 2-year look back period starting from the first quarter of 2016 to capture prior cardiovascular procedures. Our final analytical sample consisted of 56,616 patients who were 45 and older and who had also undergone a cardiovascular intervention. These patients were later hospitalized for non-cardiac surgeries. So we have a large data set with over 56,000 people, and this allows us to analyze post-operative outcomes across different time intervals following those cardiovascular interventions. We are still in the early phase of analysis, and we've only been able to complete the unadjusted analysis for now, so I will discuss those results. But essentially, we carried out a chi-square test and a Fisher's exact test to get a baseline characteristics of the patients. And then we carried out a logistic regression and also the Wilcoxon-Ransom test to get p-values and confidence intervals for 2 different types of adjusted analysis that we did, which I will discuss now. So the first analysis that we conducted were unadjusted outcomes, primary and secondary endpoints of patients undergoing non-cardiac surgery after TAVR, stratified by time interval. So from this table, there are patients who have different adverse outcomes after a non-cardiac surgery, and these patients are classified into the time group of when they had the TAVR. So if a surgery was performed in less than 1 month after the procedure of TAVR was conducted, and then they unfortunately passed away, those were put into the TAVR in less than 1 month period, and then they had an all-cause death. Therefore, we had 2 different comparisons here. So we compared the people who were in the less than 1 month group of the TAVR to the people who had the greater than 6 month period of TAVR. And then we had the p-value, which is PA values here. And similarly, we compared the 1 to 3 month periods to the 6 month period. We also compared a different cardiovascular intervention, which was SAVR, and we compared TAVR and SAVR, and then the same time group, and then we got the p-value, which is the PB value here. So from these results, we found that there was no significant difference in major adverse cardiovascular events, which is also called MACE, or all-cause death, across time intervals prior to the 6 months. However, we found that TAVR in less than 1 month had a notably higher percentage of stroke, as well as high bleeding rates, though a slightly shorter median length of stay was also seen. In the TAVR 1 to 3 month period, we found a lower risk of myocardial infarction and stroke, but we saw higher rates of bleeding. And then in the TAVR of 3 to 6 month period, we did not find any significant difference when compared to the TAVR greater than 6 month period. Therefore, when comparing SAVR to TAVR, we observed no difference in MACE, but some variations in mortality, length of stay, bleeding, and particularly within the first month period. This suggests that while delaying a non-cardiac surgery for at least 1 month may reduce complications, waiting beyond 3 months may not provide any additional benefits. The second unadjusted outcomes or analysis that we conducted were patients of undergoing NCS after TAVR, stratified by time interval, as well as the receival of aspirin and aspirin, which can be used as a blood thinner. So we found that TAVR in less than 1 month, aspirin use was associated with higher bleeding rates. And for TAVR in 1 to 3 month period, aspirin was linked to lower rates of MACE as well as stroke. And lastly, for the TAVR in greater than from 3 to 6 months, outcomes were similar regardless of aspirin use. So in conclusion, we found that comparing patients with and without aspirin at the greater than 6 month period, aspirin users had a higher rate of MACE and stroke, but lower rates of myocardial infarction. This can highlight a complex role of aspirin in balancing bleeding as well as cardiovascular risks. Now, I'll discuss the strengths, limitations, and the future recommendations for the study, as well as the public health implications that are associated with the study. So our findings suggest that waiting at least 1 month before undergoing non-cardiac surgery after TAVR is crucial to reduce complications. But further delaying surgery beyond 3 months may not significantly alter any major cardiovascular risks. The role of aspirin is still iffy, but with benefits for stroke and MACE at certain time intervals, it is recommended, and then there may be an increased risk of bleeding. The strengths of the study is that our study has a very large sample size with over 56,000 patients, making this one of the most comprehensive studies in the area. And we also accounted for medication use, such as aspirin and other inhibitors, which have not really been included in any other study before. The limitations are that our data set may have some missing values, but that is only because of the data set that we received, and it is the problem with data collection. It could impact the accuracy of outcomes such as death or stroke. We were also unable to analyze all other cardiac interventions. There are multiple cardiac interventions which can be evaluated, but because of time constraint, we focused on 1 or 2 in particular, which means that our findings cannot really generalize to other procedures. And finally, the future recommendations are that expanding the study to include additional cardiac procedures such as MVR replace or repair, as well as investigating the impact of other medications that were present in the data set. And lastly, I'll discuss some public health implications of the study. The first one is that we are aiming to reduce perioperative complications as well as mortality. Our study highlights the importance of timing non-cardiac surgeries after cardiovascular interventions, which can help prevent post-operative stroke or myocardial infarctions, and ultimately reducing morbidity and mortality rates. The second public health implication is optimizing clinical guidelines for safer surgical training. This can refine surgical guidelines and make it more data-driven, preventing unnecessary surgical delays that could impact a patient's health. And lastly, medication management and personalized treatment plans could lead to more personalized perioperative management strategies where aspirin therapy is adjusted based on the timing of surgery and patient-specific risks. And thank you. I hope you found the presentation interesting. I am excited to work on it more and conduct some adjusted analysis. Please reach out to me if you have any other questions and would like to chat more about the presentation.
Yes, thank you, Andrew. It was a very nice presentation. There's a quick question from the audience. And it's about, is the clinical database used here public available or just
I'm not sure if it's available to the public, but it is available if you reach out to the company, and they can provide the data set.
feel free to reach out any of our speakers. And I really want to thank our speakers for their participation, especially during the spring break of New York. And have a great week.